Hello, my name is Dr. Evan Levine. I'm a licensed cardiologist with over 30 years of experience practicing medicine in the United States. Now, any information expressed here is based off of my own research and is solely my opinion as a practicing cardiologist. So our discussion is a one man's opinion for educational purposes and does not substitute for professional medical advice or establish a doctor-patient relationship. Please consult a medical professional or healthcare provider if you're seeking medical advice, diagnosis, or treatment. Thank you.
Thank you so much for that, Dr. Levine. I want to thank you for taking the time out of your busy
Pleasure.
weekend and joining us. I want to thank everyone for another episode or another podcast interview on the Self-Care Forum. So we are joined today by Dr. Evan Levine. He is a cardiologist. He is an author, and the book of which we will be discussing once more, it's called What Your Doctor Won't or Can't Tell You. Now, this is a revised edition, but I had the opportunity to read this book, and boy, there is a lot of information in here. And I am certain that, not only as a healthcare professional myself, there were so many things in this book that I didn't know, right? And as someone who tends to want to know the truth and want to know what's really going on in the background and what's going on behind all of these decisions made by hospitals and really the healthcare system as a whole. But you really shed a lot of light on there. But before we get into the contents of the book, I want to know a little bit about the man. Who is Dr. Levine? I know you're a humble man, but who is Dr. Levine in your own
I
words?
try to be very humble. Honestly, I'm a kid who grew up in the streets of Brooklyn, worked my way through school and med school on my own. I like people and I like taking care of people. One of the reasons why I wrote this book is because I didn't like what I was seeing. The old for the root of all evil is money. And that's what I was seeing in healthcare, and that's what we're seeing now amongst some people. And I was sort of disgusted by what I saw, and that's one of the reasons I wrote this. As far as I'm concerned, I love seeing people. I used to tell the medical students, I'm an imperfect person like we all are, but when I close the patient's door, I'm as perfect as can be. I accept no money from pharmaceutical industry. I will not have lunch with a pharmaceutical rep. I may like them, but I'm not going to have lunch with them. I'm not going to take their money because I don't want to owe them anything. And I'm going to make a decision for the patient. When I was working at other hospitals, for example, if the patient I thought would do better in a competitor's hospital, they went there. And that's who I am. That's the way I work. Some people don't like that. I want my kids to be proud of me, and that's more important. And so that's who I am. I try to be as honest as possible, that's the way I practice medicine. My goal is to make someone better. I don't look at the money. It's hard for a lot of people to do that, I think.
Yes.
But I do not. I do not overtest. I do not overprescribe. I do not write branded medications if there's generic medications. And again, I do not send patients for tests to improve my RVUs or income. I never have, never will.
And
I take home a little bit less money than some other people, and I'm happy with that. And that's the way I operate. That's why I wrote the book.
And I appreciate that, Doctor. And that's what makes you unique in a lot of ways, because it's for someone who's gone to school and has gone through the rigor of med school, and then you practice cardiology and you did years of training and residency. When you get out, you're in a lot of debt. And so the temptation now is, look, you've got to pay off this debt. You've got to make a lot of money just so you can establish yourself. And so the temptation arises to cut corners, to then establish these relationships with a lot of these sales reps. And a lot of the public isn't aware of just what goes on in the background. And I think you did an excellent job of exposing just a lot of things that you saw with your own eyes as we get into the book. But, you know, there's got to be something about your upbringing that made you, you know, take the straight and narrow path, because I
Yeah.
can imagine it's difficult.
You know, I came from a blue collar family. My dad worked 2 jobs. I think most of my family sort of, I'm not going to say taken advantage from the healthcare system, but we just didn't know who to turn to, who to ask questions about. And so when I went to med school and graduated, I became, and that's one of the reasons I wrote the book, you know, cousins, uncles, aunts, everyone was calling me for advice. And because they really had no one else to ask. I mean, you get sick, you go to a doctor, maybe you don't know the physician, it's the first time you met them, it's an emergency, you need, you know, some type of surgical procedure, you don't have a lot of time, right? All these hospitals, especially smaller community hospitals, are getting into more complex procedures. Maybe the volume isn't as good as a major hospital, and you know, some administrators want them to do procedures that maybe it'd be better off for the patient to go elsewhere. These are the things that you really have to try to get a quick education about.
Mm-hmm.
And that's what I do with my family. That's what I hope to do with the book. That's what I do when patients see me. I mean, the other day I saw a patient for heart failure, but I saw he also had severe spinal stenosis. So I know he came to me for heart failure, but I directed him to a neurosurgeon that I would trust. Not that he came to see me for that, but I just thought that he was going to the wrong person, you know, a local doc. Some of these, my caveat, my warning to people is that for really complex procedures or surgery, to seek out and do your homework. I was called by an old friend a couple of weeks ago, who I've known for years. You know, again, I'm from Brooklyn, so one of my friends is a plumber. He does better than I do. That's my joke. And he goes, hey, Evan, I'm with my relative here in New Jersey, and he had 2 stents. And my son says to him, you know, if you were buying a car, wouldn't you go to a couple of dealerships? And he's reciting my book is what he's doing. He's playing a joke on me because that's my analogy. It's kind of funny, right?
Yes.
When you go buy a car, you go to 2 or 3 dealerships, you get in the car, you check the mileage, you check the reviews, you test drive the car.
That's right.
And yet when you need a major surgical procedure, you go to one doctor.
Yeah.
Right?
Yeah.
It's crazy. People ask me a question, and I wrote about this in my book. What if my doctor gets offended?
Yes.
Right? That I want a second opinion. I need the records. And so I've never been offended. My answer is I've never been offended. I'm not right all the time. I am human. And if you're seeing a physician that's offended, well, that's a sign you should leave the physician.
That's right.
Because that physician's hubris is going to taint his decision-making at some point. You want someone who's very open-minded, whose sole interest is to help you. And if you're seeing someone who has that sense of arrogance that may taint his and produce a biased decision, that doctor's not for you. So that's my answer. If you're not sure, or if it's a complex problem and you have time, always get a second opinion.
Excellent point. Just a reminder to everyone, Dr. Levine is board certified in internal medicine, cardiology, and nuclear cardiology, and he obtained his MD from City College of New York and Mount Sinai School of Medicine. He actually graduated summa cum laude. So he is a very bright man. Not to inflate you. I know you're a very humble man. But let's start there, doctor. You know, you gave the analogy that, look, if you were going to buy a car, you know, you would go to different dealerships to see who would give you the better deal, who would, you know, maybe somebody tries to rip you off, or maybe somebody just tries to pawn off a lemon on you. But let's talk about how to choose your doctor. For a lot of people, you know, for them, they just go with the doctor they've known, or, you know, the doctor
Right.
that the friend has recommended. So how, in your own words, in your opinion,
Right.
how should someone choose, you know, a doctor?
So it depends. So if we're talking about a primary care physician,
Mm-hmm.
the doctor, you know, the one that you're going to see, not a cardiologist, you know, is a difficult, a complicated question. So clearly, you want the physician to be board certified, okay, in internal medicine or general practice.
Mm-hmm.
I tend to have a bias towards physicians that are affiliated and work with large teaching hospitals, because they've vetted the physician more so
Mm-hmm.
than a very small community hospital
Mm-hmm.
or maybe a small medical group. So they've done somewhat of that vetting process, right? Um, Now, there are other little things that you need to look at. If you go into the office and it, it's dirty, it's not clean, it's something that you'd be unhappy with sitting in that office. It's not good for you. If
Mm-hmm.
you call up on the phone to make an appointment and it takes you 20 minutes to get through, again, that says something as well. I mean, again, I don't accept big pharma money. I never have. There are sites like ProPublica, which you can go to and see if the physician is accepting large sums of money from me. That's a strike against the doctor. There
Mm-hmm.
are physicians, and I know them, that accept over $100,000 in, last year because of COVID that didn't exist, but in pharmaceutical talks, which is it's a quid pro quo. You prescribe the drug, we give you a
Sure.
talk,
And a
and
lot of
and they
people
can
don't
get
actually
paid.
know. And a lot of people don't actually know the relationship between,
Correct.
you know, the doctor having a bias towards certain drugs, certain
Of
prescriptions,
course.
certain brands, and the fact that there's something going on in the background. A lot of people
Yes.
don't even get to, you know, they never get to see what's going on in the background. But before we get into that, doctor, you know, you mentioned, you know, it's important to make sure that your doctor is board certified. Now, the board certification process is just the exam to make sure the doctor's competent. Am I right?
That's correct. I mean, your doctor still may not be a very good physician. And let me say, it's not that, as I mentioned in my book, it's not that difficult to pass the board exam.
Mm-hmm.
Okay. But nevertheless, it's something to look at, right?
Mm-hmm.
Um, you can go online and see if there's any professional misconduct about the physician. It's clearly, I have a visitor here, so forgive me. It's clearly easy to find out. I like, if you're going to get recommendations, better to get recommendations from a nurse or a medical provider who knows the physician.
Sure.
Some of my recommendations over the years came from nurses at the hospital when I was rounding, family members, etc., because they see how the physician works.
Mm-hmm.
That's very important.
Now, what
To
about, thanks, doctor. What about, you know, and I agree with your point of getting recommendations from health professionals because they actually see them in action, as opposed to sort of relying on your friends, because your friends don't really see what goes on. They don't see
Yeah.
everything that goes on. They just sort of see the front that is presented. You know, what about in terms of advertisement? You everywhere you go, you see a banner, you see advertisements, even online websites will actually publish and proclaim this doctor is the greatest thing. How should we feel, or how should we look at that?
I don't want to get myself into trouble, but I'm completely dismissive of those.
Okay.
Completely dismissive. It's meaningless for me.
Mm-hmm.
They're good marketing people. I don't know what that means.
Right.
Okay, I don't know. Again, if maybe it's affiliated with a major university setting, and that university is a top ranked hospital, that might be something different. But you've seen these advertisements on things like placemats at diners. For me, if anything, that's something I'm staying away from. It kind of cheapens my profession.
Right.
So yeah, there are a lot of doctors. I see them out there. They advertise. They're opening up clinics all over. Again, I don't want to get myself into trouble, but I'm dismissive of all that. It's meaningless for me. If anything, again, the type of advertisement they might do is it might be a strike against them as far as I'm concerned. One of the things to be wary about, oh, I love my doctor, he does all these tests. Again, that's a lay person saying that, especially people who have Medicare and maybe some supplemental coverage. They have paying very little out of pocket, and that's not right. You know, I always joked around with some of my patients. I said, I'm an undertester. And they go, what does that mean? I said, I'm an undertester. That means I drive a Honda and the overtester drives the Maserati. That's what it means. Okay? People have to be cautious. Testing is not good medicine. Overtesting is not good medicine. Overtesting often creates a healthcare burden. For example, the task force now says carotid duplexes for asymptomatic patients. Getting the sonogram of your carotid artery is not helpful. In fact, it may be a trend towards harm. Doing stress tests on asymptomatic people, by and large, is not appropriate. Things of that nature. But, you know, hey, some people might say, wow, my doctor is very thorough and he does all these tests.
Right.
You know, I'm not saying, you know, obviously there are some tests you need. You need a colonoscopy, things of that nature. But all these fancy cardiac tests, you know, often are not necessary and creates a burden to the system. And not only a burden to the system, but may be a burden to yourself, even if you're not paying out-of-pocket expense. Doing wrong tests sometimes leads to even more tests, and some of these tests may not be benign. There may be a risk. So I'd be cautious about seeing doctors that get just lots and lots of tests.
And you know what? That actually resonates because in the U.S., we spend nearly $4 trillion each year, or actually in 2020, just in healthcare alone. And so people don't understand how all of these tests, you know, the over-testing, not only does it contribute to the overall U.S. budget, but, you know, we have to understand, a lot of people don't seem to get the connection between sort of how doctors testing and sometimes there's a financial incentive there, you know, to the more tests you prescribe, even if they're irrelevant, you know, the more money you might get. And so I think that's a relationship that some people haven't you know, ever thought about. Now, in terms of testing, I want to stick to that point because it's so relevant. In terms of testing, what about you know, what sort of doctor should be testing you? You know, if you go in for a headache and the doctor thinks there's something wrong with your knee and they want to test you, I mean, how should you respond in that scenario?
That's a very general question. I mean, something is wrong with your knee. You have knee pain, for example. Again, I'm a cardiologist, but so it's a little hard for me to say. Depends upon your age. Depends on how much pain you're having. You know, there's a lot of depends here. So what's happening now, I don't want to get tangential, but what's happening now is that these poor medical doctors, and I mean that, the general practitioner and the internist, okay, who are working for these big organizations, they have a tremendous burden on them. Documentation, hitting certain metrics in documentation, dealing with electronic medical records, dealing with getting tests approved, right?
Yes.
And so sometimes they're kind of quick to order a consult because the decision-making process is a lot easier to order a consult. Like, you know, I'm so overburdened, I don't have enough time. Oh, your knee's still bothering you. See an orthopedist. You see? And then you're down the orthopedic path. So
Now, one of the points you make in the book, especially for those who are infirmed or who may be elderly, is if you ever find yourself, in a situation where they're ordering tests of which you don't understand, get a family member, get somebody who's going to, glance at ask questions, because
yeah.
essentially what I'm getting at is you don't want one doctor specializing in one thing ordering tests for another thing, just so they might, maybe there's a financial incentive there, right?
Well, again, you have to look at the big picture. And when I used to round in the hospital in charge of the telemetry unit, I used to go in and I used to find these tests ordered by the PAs or the NPs or the night doc. And I would basically say, let's look at the big picture. What are we going to do with the results of this study in a 96-year-old person with dementia? Why are we doing the study?
Mm-hmm.
So when I look at a study, and I agree with you, you need to get a family member involved to help make that decision. Before you do any study, whether it's young or old or whatever, the question a physician should ask, and you should ask the physician as well, what am I going to do with the results? Right?
Mm-hmm.
So here's a little bit of a funny story.
Yes.
I remember the exact day. 2 years ago, we had an ice storm near my house. I remember it was Martin Luther King Day. The kids were off, and the people were going to come over. And I said, let me chip the ice. And of course, I fell on the ice, and I dislocated my shoulder when I fell down. And I was very upset with myself. So I'm a little crazy. I banged my shoulder back into place. And the next day I went to the hospital and I was in pain. And first I called my buddy, the orthopedic surgeon. Oh, Evan, you got to get an MRI. What are we going to do with the results? I said, why can't I just wait to see if it gets better? I can move it. Yeah, I guess you could. All right. Then I called my friend, the physiatrist. Can you meet me outside the ICU? Yeah. What are you, crazy? You need physical therapy and blah, blah, blah. You should, I go, why can't you give me the exercises to do at home? I never had an MRI. I never saw physical therapy.
Mm-hmm.
In a month's time, I was better.
Mm-hmm.
Nothing done. Okay. Now, again, it's like a reflex, get this test, get that test. But I asked the question, what are we going to do with the results? I can move my arm. If the MRI is normal, you're going to send me to physical therapy anyway to begin with. And if it's not, if it's normal, you're going to send me to physical therapy also. So my feeling was, let's wait and see if it gets better. But the reflex is test.
Mm-hmm.
And especially for a lot of folks that have huge deductibles now,
Yes.
those tests are very expensive. We have healthcare insurance, and it isn't what it used to be.
Mm-hmm.
Most of these plans have high deductibles, and they're quite expensive. Personally, I think these high deductible plans should be outlawed, because what it does is discriminates from people who can afford and not afford.
Mm-hmm.
And, you got 3 kids and you got to pay bills. And at nighttime, you're getting chest pressure. And, if you go to the hospital, it's going to cost you $5,000. Because you have a $5,000 deductible, you're going to hit that in the ER. Maybe you say to yourself, I stay at home. Next thing you know, you had a heart attack. So getting back to your question, before you have a test, ask the physician what they're going to do with the results.
Mm-hmm.
And if you need that test now, your knee is bothering you. I don't know if they're going back to the knee. Take some NSAIDs for a week, see if it gets better. I mean, it all depends on the severity of it. So it's a tough question to ask. For heart questions, I can be more specific.
Excellent. Thank you. Now, to that point, many times tests may lead to some sort of surgical procedure or medical intervention. But in your book, you encourage your readers to always seek a second opinion. Can you elaborate on that? What's the
Sure, I'll
use
give you
of
an
getting a
example of
second
one
opinion?
recently.
Yes, sir.
Um, a neighbor, a friend of a neighbor, called me. She was told at a local Connecticut hospital that she probably required surgery, that she had an unusual finding. Okay.
Mhm.
And my answer was, you're going to a very good community hospital, but it's not an academic hospital where they see hundreds of people like you a year, not two. And as a good neighbor, I made a call and got her to see one of the chiefs of the minimally invasive surgical teams. And she saw the doctor a couple of times. And this week she told me that they said she never needed surgery.
Okay.
Good second opinion there, right?
Yes.
Okay. So what I'm saying is, for most folks, you really have time to get a second opinion.
Mhm.
Even for heart disease, you have a leaky valve or stenotic valve, or even if you had a positive stress test, it's unusual that it's an emergency, right?
Yes.
So one of my Levinisms are sayings that I tell my friends, neighbors, and relatives, including someone that saw me last week. If you're willing to drive to Manhattan for a great meal, shouldn't you be willing to drive to Manhattan for great health care?
Mm-hmm.
If you're willing to make that hour drive to have your favorite Italian or Chinese or whatever, French food, in those circumstances, especially if it's not a run-of-the-mill type of procedure, right?
Yeah.
Why not make the drive? That's my recommendation. So if people who know me, they call me, if they're a patient of mine, again, whether I see them for heart disease or not, it's a pleasure
Mm-hmm.
to get them a second opinion, which I try to do.
Excellent. And of course, you emphasize the point that you want to get a second opinion from a physician who's not affiliated with the institution from whence you got the first opinion. That way you get.
Absolutely.
Yeah.
Very difficult. I'll give you a prime example of that.
Mm-hmm.
Many years ago, we had a patient come in with recurrent little heart attacks, okay, to the hospital I was working at back then. And he had an operation by the chief of the heart surgery division years before. So he was the person, that was seeing the patient with me. And he refused to operate on the patient. When I spoke to all the other heart surgeons, they all said he needed an operation. But they were too fearful. They had too much cowardice, use whatever word you want,
Mm-hmm.
and no one would take over the case. Got it?
Yeah.
I transferred the patient from our ICU to another hospital. What did that do for me? I got a hug from the wife, and the chairman tried to disinvite me from the yearly party, the
Oh boy.
heart party. That's what I got. You see what happens?
You get punished.
You get punished for damaging their ego.
That's right.
You get punished for doing the right thing. And I'm telling you, very few people are stupid enough, like I am, to do the right thing, because it's, even writing this book,
Mm-hmm.
I've created quite a few enemies amongst the healthcare providers, because there's a secret code of silence. It's sort of akin to, I wrote something about this a while back, sort of akin to the blue line, back especially in the 80s and 90s in the police.
Mm-hmm.
No one said anything, right? I call it the red line. No, medicine. Don't say anything. You're the bad guy, even if you're doing the right thing.
Yeah.
And that's what happens. So again, you got to be educated. Go get a second opinion. I think the most important physician you're going to have and take your time finding one is your primary care physician, because it's all about being honest. Okay,
Mm-hmm.
because medicine is not difficult. Okay, I'll be frank. I do a little plumbing and electrical work with my friends. I find that incredibly difficult.
If you can do
Medicine
a
is
heart,
not
you
so
can do
difficult.
plumbing, right?
Yeah, right. Medicine is not that difficult. The most important thing, and you have up to date. You can look up all these things today. The
Yeah.
most important thing is two things: honesty and lack of hubris. Those are the two most important things in a physician. The lack of arrogance, the ability to say, I'm not sure, and the honesty and dedication to the patient and
Mm-hmm.
not the wallet. This is the most important thing. That's the doctor you
Indeed.
have to find for your internist.
Indeed. And I think it goes back, to a point you made earlier, Doctor, or when you said the love of money is the root of all evil. Anyone who is willing to make the big bucks at any cost will undoubtedly sell you short.
Right? But it's infiltrated every part of our society. Why is medicine immune to that, right?
Mm-hmm.
Of course it's not.
Now, I want to, going off of what you mentioned earlier, you seem to have a preference towards hospitals with an academic affiliation. Just give us a little bit of a little bit more detail. Why do you tend to prefer those hospitals as opposed to your small local hospital? What do they have that maybe your small local
Right.
hospital not have?
Well, I think it's important that small local hospitals have the ability to treat you emergently, no question.
Mm-hmm.
Stroke, cardiac cath, the STEMI, open up your artery, incredibly important, right?
Mm-hmm.
But it's all about the quality of the physician and the quantity of cases they do, right?
Yes.
So if you're going to go for a complex pancreatic procedure, Whipple procedure, or a complex valve repair, do you want to go to a smaller hospital that does, 2 a year?
Mm-hmm.
Or do you want to go to a center that does 2 a day? I mean, it's obvious, right?
Yeah.
We're not supposed to talk about this, okay?
Mm-hmm.
And it's dangerous sometimes to discuss this, but to be frank, we all know what the answer is.
Right.
Right?
Right.
So yeah, I know for colonoscopies, for, emergent stent placement and things of that nature, yeah, a good community hospital, great, right?
Mm-hmm.
But again, we're talking money here. So the community hospitals are trying to survive. They try to do more complex procedures. But do you want someone who's doing just a couple a month or a couple a year? I mean, clearly, you know the answer, right?
Of course. Of course.
Yeah.
Of course, great point. And now to that point, let's talk about the responsibility that we all have towards our healthcare. Now, there's a list of essentials that you mentioned that everyone, certainly, especially if you're, someone with chronic diseases or you're accident prone or you have poor health, you should always have with you. And you actually go into detail as to some of the reasons why, you should always carry these things. Some of these things include, you should always have a list of your medication, a copy of your most recent visit with your primary care, and you should always have that with you. God forbid you get into an accident or a stroke
Right.
or something happens and you wind up in a hospital somewhere. And you talk about why it's important for them not to assume things about you, but it's so much more important for them, for the doctor seeing you maybe in the emergency room, to actually know which medications you take. And you actually gave an example of a doctor who saw a patient and saw that there was a particular medication that the patient should have been on, but they weren't. Little did the doctor know, the patient had developed an allergic reaction to that medication,
Right. That
gave the
was
medication,
twice.
and the patient
Yes.
died. Can you elaborate on that story a little
Sure.
bit, please?
It was an elderly patient, not a well-educated person or family, and he had heart failure. Now, typically, that patient should be you're in the business, should be on an ACE inhibitor, right?
Mm-hmm.
But he wasn't on an ACE inhibitor because he had angioedema, which, as you know, is life-threatening, where the throat swells up and can cause asphyxiation.
Mm-hmm.
So he goes to he got himself into heart failure, and he went to a hospital in the New York area. And here's another thing this is another important thing. Physicians have sometimes very poor communication skills. They're too busy. They think they're too smart. They don't call. And this
Mm-hmm.
is endemic to the system. When I was in charge of the telemetry, I told the PAs, we have to call every doctor. Even if you didn't respect the physician, you have to call them, okay? But from my own point of view, I've had patients go into hospitals locally, never a call. So, of course, they didn't call me. They assumed I was a fool, I guess, that his cardiologist didn't have him on an ACE inhibitor. So they gave him an ACE inhibitor, and guess what? He got intubated and almost died.
Wow.
Then the family is on vacation in South Carolina visiting relatives, goes into heart failure again, goes into a local emergency room, probably said, this New York cardiologist is an idiot, not on an ACE inhibitor, gets on the ACE inhibitor again, and oh my God, he gets intubated again. I can't make this up.
No.
I cannot make this up. So, I wrote down for the family, finally, no ACE inhibitors. Dad almost dies, has angioedema.
Mm-hmm.
But there's a lot of things that fall through the cracks that the people just don't hear about. They don't report the cases. Things happen. Look, in the best of worlds, when we started with this EMR system, the country really screwed up, amongst other things, in our I call health not care system. The EMR, electronic medical record, should have been the government, right, asks the Googles, the Microsofts, whatever, right,
Mm-hmm.
to come up and let's see who can make the best EMR, and we have one EMR system.
Across the country.
So when patient X goes into hospital Y, they can access and see everything, right?
That's right.
But guess what? That didn't happen. Now, by pure coincidence, especially amongst the larger hospitals, and you guys just got into this, I would say that Epic appears to be kind of winning the battle.
Yeah.
And so there is some communication because of that. But having said that, not always. And if you end up in an emergency room, at least have the list of medicines and allergies. I used to play a game. Just show me the list of medicines. I know what the patient has, right?
Mm-hmm.
You can see they have diabetes, coronary disease, hypertension. You see the meds.
Yeah.
You know what they got.
Yes, sir.
So you need to carry the list of medications and your physician's number. But I'm telling you, even if you have that number, I can't tell you how many times I've called hospital administrators and gave them a bit of heck and saying, come on, you guys never called me. And they're completely, dismissive and we'll do better next time. But there's a terrible lack of communication.
Mm-hmm. Understood. And really, it comes down to us, the patients. It's incumbent upon us to make that demand if you ever find yourself hospitalized.
Yes.
One of the first requests you want to make, in addition to making sure the nurse or the doctor or the PA or NP overseeing you knows a list of the medications you currently take, some of the diagnoses that you have, but you also want them to reach out to your primary care. because the primary care can provide additional detail that may be life-saving. And so, you know, the lack of communication is never good because a lot of
It's
mistakes
time consuming. It's time consuming, and maybe the doctors are overburdened as well. But
Mhm.
I would be bold enough to tell the physicians in the emergency room or on the floor that you go to, I am not accepting any of your care until you have a conversation with my physician, and I want you to document that.
Great point. I mean, who knows you better than your primary? Who knows
Correct.
you
And
better?
he's got the EMR, he can look everything up. And again, you don't want to get a medication that you're allergic to or something that caused arrhythmias or you had a bleeding history.
Hmm.
You know, there are so many caveats or fears that, you know, again, I've been in the business a long time. And I've seen this, you
Hmm.
know, pen allergies, people got, you know, bleeding histories, they got blood thinner of that nature.
Yes.
And bad things happen if you don't know the patient. So
And also,
absolutely, I would not allow. I mean, unless it's an absolute emergency.
mhm.
But aside from, you know, it's a life or death matter in 2 minutes, I would not allow them to continue care unless they reached out to the physician.
Hmm.
I
Excellent
over
point.
the years, I've been in the hospital, you know, years back I'm not working there anymore. And I've walked on the floors and I've had patients scream, Dr. Levine, did you know I was here? No, I had no idea you were here. No idea.
Right.
Unbelievable, right?
Right. Exactly. Exactly.
Unbelievable.
Yeah. So it's up to the patient to really drive that point home. And you know, you've got to be bold enough because it's your health. If any mistake gets made, you know, you'll be the unfortunate recipient of said error. So you've got to be your own advocate
Yeah.
in that
You don't
sense. And that's a
you don't
great
want
point.
somebody telling you they're sorry. Absolutely.
Exactly. You know, hopefully you're alive to hear that.
Yeah.
You know, but one other point you make, you know, with regards to, you know, your hospital stay is it's important for people, even if it's covered by insurance, it's important for people to review, you know, their discharge orders. You know, it's important to make sure that before your discharge, I think, you know, if you look at the economics of, you know, hospitals and sort of the business of hospital beds and keeping people hospitalized and keeping the beds filled, but for not for too long because of the incentives that are there. You know, sometimes there may be a situation where the exactly where you're kind of being pushed out. And if you don't feel like you're able to go home or you should be going home, it's up to you to speak up. Am I right?
Yes, absolutely. You want that documented and, you know, realize that as good as the nursing staff and the social workers are, they're all sort of under the gun, right? To
Hmm.
get the beds cleared out for other people.
That's right.
Sometimes they error. And so, by and large, if you request an extra day because you're very uncomfortable, um, they have to review it. And usually you'll get that extra day. The
Hmm.
other thing is, and that's could be very dangerous, is that before you go home, and if you're on new medications, make sure that they spoke to the pharmacy or that the pharmacy has the medication and that it's covered by your insurance.
Very important.
Okay. So, for example, you know, you had a stent placed and your physician wanted to give you Brilinta, but it's not covered, and you have a prescription, it's going to be $400 a month, but they could have given you generic Plavix, clopidogrel, which is covered, right?
Hmm.
And you don't know this, you just had a heart attack or a stent placed, you just want to go home. The next thing you know, you have no medicine. And if you don't get the medicine, the stent's going to close up. And then you're going to be back in the hospital with another heart attack.
Right, right.
So before you go home, insist on the staff making the call that the pharmacy has it and that your medication is covered. And if it's not, ask for an alternative if there is one.
Excellent. Now, to this point, let's talk a little bit about brand name and generic drugs. Now, as I understand it, you're a big fan and a big proponent of generic drugs. And is it only about the fact that it's cheaper?
No, most of the good drugs are generic now, especially for hypertension. My wife laughs at me because she knows I'm a generic person for medication. Again, you know, I used to sit down with patients, less so now because a lot of the good drugs are generic. And I used to use my phone as a calculator, and they'd come in to see me, and I said, well, we could do this, that, or the other thing. And by the way, I just saved you $2,800 in a year. And there's no, you're not getting anything better.
Mm-hmm.
Okay. So if there is an alternative that is generic, then take it. If it's equally as effective. The other thing is for hypertension, if you can combine medicines, you know, one is better than two. Once a day for everyone, if able to.
Mm-hmm.
People don't realize, and the doctors and healthcare providers don't realize, and I've asked this question to a lot of people, they didn't know the answer. When you go from a medicine that can once a day to twice a day, compliance diminishes by up to 15%.
Wow.
So the other Levineism is, my patients, if they can be on once a day, I play games, I find a once a day. Everything once a day, especially for hypertension, if I can get away with it.
Mm-hmm.
But nevertheless, I see people, especially elderly people, that are on 7 meds. One is 3 times a day, one's 2 times a day. And I'm like, oh my God. You know, I think your doctor should have to take this. It's impossible.
They've got the little pill packs, you know?
It's impossible, though. Make it as simple as possible if you're able to. So that's another thing. Reduce the amount of pills. Make it as simple as possible.
Mm-hmm.
You know, how many patients are on aspirin that don't need to take aspirin? You know,
Right.
a couple of years ago, there were a number of trials that show aspirin has no benefit, maybe increased risk if you're over 70. So I see a lot of patients over 70 on aspirin. There's no indication. They're off the aspirin.
Mm-hmm.
Taking all these multivitamins that probably have no benefit, come off that.
Mm-hmm.
They're on a thiazide diuretic and an ARB. Put them together. One less pill.
Yes.
You know, I'm very forgetful. I could be on, I remember I had a sinus infection. I was on Augmentin, and I literally forgot if I took the pill that morning. I'm sitting there, I'm like, oh, did I take that pill?
Mm-hmm.
And I had to count the pills in the pill bottle and go backwards to figure it out.
It's a lot of
and
work.
Again, I said to myself, what about the 80-year-old, right?
Mm-hmm.
That's on 8 meds. Yeah, if they have the pill pack, sure, that's helpful, but still, it's kind of hard. So generic meds when able to. Stop medications that have no value.
Yes.
And try to make everything once a day if you can.
If possible. Oh yeah. And I think nowadays there are more extended release versions of drugs that, you know, facilitate that process. So I think that if people were to, if someone's taking, you know, metoprolol, for example, 3 times a day, you can always ask for a once daily form of that drug. And
that's funny you say that, because I get sick to my stomach when I see that.
Mm-hmm.
And they all, and the other thing that really ticks me up, and I used to tell the PAs, and I'm going to use a dirty word, the SHIT word, okay? I don't know why it's a dirty word, but I used to tell the staff, shit or get off the pot. You're giving an 80-year-old 75 milligrams of metoprolol succinate, or worse, metoprolol tartrate, 75 milligrams twice a day. And well, I will tell your audience what that means. That means they got a 50 and a 25 separate pill. and then a 50 and a 25. Ridiculous. Shit or get off the pot means give them 200 XL. Very few people need 150 versus 200.
That's true.
Give them a 200 XL once a day. I just saved you 4 pills, just went to 1 pill a day. But I continually see this, or pill splitting. Take 1.5 pills of metoprolol succinate. You know, they got to cut them in half. Ridiculous. Absurd.
Absolutely. And I think people have to understand that not only does that save you money, you know, but it oftentimes increases your compliance. Like it's if you only have to take something once a day, you take it and then you go about your day. But if you've got to take it multiple times a day, it's very easy to forget, especially if you're someone who's very busy or who stays, you know, and
it's a nuisance. You need to enjoy life. You can't be waiting, you know, to take a pill all day long, right?
That's right. That's right.
Crazy.
Well, and so talking about this, you know, the idea, you know, we have ads, TV, pharmaceutical ads on TV all the time. And so, you know, when it comes to, and this is the big elephant in the room, right? Big pharma or the pharmaceutical industry. Now, what is the impact of direct to consumer advertisement? How do you see that having had impact?
The worst crap in the world. Only the United States and New Zealand allows to direct to consumer advertising for pharmaceuticals. And I'll give you a story and I'll send you to a link. I was on the Today Show when the book first came out about 15 years ago. Okay? Before I went on the Today Show, 2 days or a day before, I had to meet with the producer. They had the questions all formatted out for me, extremely professional. I asked the producer, you know, how come there aren't any questions about the chapter on pharma? And she said, I read it. No one's going to be interested in that. Again, even though I'm from Brooklyn, I'm a good guy, so I'm naive. And I said, that's kind of strange because I had some pre-published books they hand out. I gave it to a few well-known physicians, and they all pointed out that the best chapter in the book, things they hadn't known or heard about, is the pharmaceutical chapter. Again, I'm very naive. She turned to me and said the following words, Dr. Levine, would you like to be on the Today Show? Yes. Well, I said, we're not going to talk about big pharma. Get it?
Yeah.
No one's interested. Okay. But she was dealing with me. Maybe I'm a little irreverent, and I didn't do this for the money, and maybe my publisher almost killed me. So they probably knew I was a little bit of trouble. So instead of putting me live, again, they made an excuse. I don't know, Bush was bombing something in Afghanistan, whatever they were doing there, running late. We're going to tape it with Ann Curry. Okay. So I went into a special studio with Ann Curry, and we're sitting there. And again, I did not do this for any other reason than to do something good.
Yes,
legacy. Okay. And I'm sitting with Ann, and I didn't want to have any regrets. And we had some time. And as we were just talking about, I think she was discussing a conjoined twins that they separated at Monty way back. And I said, you know, Ann, I have a question that's really bothering me. Your producer warned me that if I spoke about pharma, that she would not put me on the air. Is that because half of your commercials are sponsored by the pharmaceutical industry?
And we see those commercials.
Right to her. She's sitting right there. She's looking at me. She said, Dr. Levine, we are a news show. We would never do anything like that. Okay? All right. So again, the questions were prepared, but I kind of segue into pharma. Now, I can imagine that the producer off wherever she was completely apoplectic, because what happened was I was lucky enough to go on this kind of cool tour around the country with the book. And I got called by my agent, Doc. He used to call me Doc. Doc, what happened? What do you mean what happened? They're not going to put your interview on the Today Show. They called Penguin Publishing and said that you performed so poorly that even if they edited it, it would be impossible to put on the air. What happened? And I said, I didn't tell him what happened, because one time before I was interviewing with the president of Penguin, and he almost killed me, my agent, because I said, I'm here just to do this. I don't even care what I get paid. So my agent pulled me aside after he wanted to kill me. But I said, I don't know. Maybe I didn't do well. It's possible. I don't know. You know, it's a big interview. Maybe I got nervous. Maybe I screwed up. I don't know. I'm going to get the DVD. So he got called up, got the DVD a couple of days. I remember where I was. I was in Dallas. He calls me up and he goes, you know, you did pretty darn good on that interview. I don't know what they're talking about. So then I told him what happened. He said, what are you, crazy? I warned you, you're not going to sell books doing this. So they wouldn't put it on the air. He couldn't get it on the air. Penguin couldn't get it on the air. I got back to New York, and now I was getting pissed off. I really was. But I knew I really couldn't call Ann Curry up. So I had a little Brooklyn smart. So I called 1-800-Flowers and said, give me the largest basket you got. You know, it was like $300. It's a huge basket. I don't know. Okay, where's it going? It's going to Ann Curry, NBC News. Is there something you want to write? Yes. Dear Ann, I thought I could talk about anything I wanted to. I guess not, Dr. Levine. Right? Next day it was on the air. They never called me. They never called me. They never called Penguin. They never called my agent. The only reason why I knew is one of the nurses said, hey, I saw you on the air this morning. Really? Yeah, you're on the Today Show. Get out of here. Then I'm looking at Amazon, like, every 5 minutes to see how the sales are going. And it went, whoop, it did a little, so bingo it was. So when you get back to direct consumer advertising, there you go. Let's imagine a newspaper. They want to do a story about pharma, or they want to do a story about even the hospitals. They're afraid to. They're afraid to lose revenue. Okay, so then you get dishonest news, and these direct-to-consumer advertising is just should not be allowed. I mean, my joke is that, hey, I'm watching these ads. Maybe I should get diabetes. That guy mowing the lawn, he looks so happy, right? This diabetes
life is great.
This is great stuff. This diabetes.
Yeah,
dancing around there, it's good.
everything except the symptoms are displayed.
Yeah, exactly. Or if they do direct consumer advertising, they should have to flip the commercial. In the beginning, they should have to tell you all the adverse effects, right?
Slow it down.
Exactly, and slow it down. You could die, your leg could fall off, blah, blah, blah. And then they could tell you the benefits. Shouldn't be allowed. But money talks.
Of course.
Other countries, European countries, do not allow direct-to-consumer advertising. It should not allow it.
It definitely has an impact on, the care that is given. But there's also another aspect of things that also influences the care that people receive. And let's talk a little bit about the influence or the impact of, the sales rep, the pharmaceutical sales rep on physicians and the way they prescribe. So the average person that's going in to see their physician, how do you know whether your doctor is prescribing something that is genuinely the best thing for you or something that they are incentivized to prescribe? How can we tell?
Right. So most university hospitals now no longer allow reps in the hospital or doctor's office. So that's a good thing. But remember, the free lunches, which I never allowed, okay, And let me just say, I don't know, every year there's a couple of $100 under my name. I don't know where it comes from. They probably have to assign it to someone. They choose me, but I don't accept anything. So the free lunches, but you see the free lunches, and it's a game, hey, I'm in sales. I need to sell a product. I'm a pharmaceutical rep. Whether the product is good or bad, they got to sell a product, right? Mm-hmm. Free lunches. Oh, Dr. Levine, you're such a nice guy, blah, 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 blah. It's funny, I do, of course, I allow the pacemaker reps. They're very bright and they know a lot. The reps know how to program pacemakers and everything. But when they come to my office, is sort of a running joke sometimes. I buy them coffee.
Oh.
I said, I'm going to flip it around. As a doctor, no, well, I'm buying you coffee. I flip it around. So, but that's not where the money is. So I know people, I've looked these things up, and I know cardiologists, they're using some medications that really have no benefit, but for one dinner talk, that's where the money was pre-COVID. Mm-hmm. This person was getting paid over $4,000.
Wow.
And he's for an hour and having dinner. And the reps, and I refuse to do that. So the reps go, oh, Dr. Levine, you won't talk to us. How about having dinner with us, going out to dinner? And my line, they used to laugh because they knew not to ask me anymore. I used to say, why would I go out to dinner with a bunch of cheap doctors when I could go home and have dinner with my family? They used to go, why would I want a free dinner? I'll go home and have dinner with my family. So I don't go to those dinners, but the doctors that talk at those dinners get paid very handsomely. Mm-hmm. And it's a game. They got to sell the drug. Drugs should be sold on merit. That's it. But that's the way the healthcare system is here. We have a very broken healthcare system. Very broken healthcare system. It's unfortunate.
And to your point, the people are the recipient of the brunt of these decisions that are being made, not knowing, and of course, unfortunately, many of them don't know where the decision, was influenced, from whence the influence came from.
Yeah.
There's reps that have, and these reps actually keep track of the doctors and which doctors prescribe, their medication. And they're able to.
The pharmaceutical industry buys the information. It's all mentioned in my book, and they know who's prescribing. So the doctor can't fool the rep and say, I'm prescribing it. They know. Doctor's not going to get the $4,000 dinner unless doctor's writing the drug. Got it? And I have seen doctors write drugs, lots of drugs. I once looked at a drug, and I found that the top 20 prescribers of that drug were also receiving the most money from that pharmaceutical company.
Wow.
Isn't by pure chance, I'm sure. So the Sunshine Act, when Obama was in power, the Sunshine Act was enacted, which mandates that the pharmaceutical industry must publish the data of how much dollars they paid the doctor. Mm-hmm. Got it? You can find it. However, the original Sunshine Act included all dollars. But the big university hospitals and the big College of Medicine and blah, 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 and all these, groups, they fought to leave out CME funded talks by pharma. So if you're going to a CME talk and your doctor is being paid $20,000 to give a CME talk on whatever topic it might be, mm-hmm. that amount of money, that ain't going to be in the Sunshine Act. You can't find out.
And it's a significant
not a good
sum.
thing. was supposed to be. Original Sunshine Act supposed to have everything. But they called their friends, the politicians, you know, blah, 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 AMA and everybody else. And lo and behold, they gave in. Not a good thing.
Money talks.
Right. So you're going to a talk. Do you know if the talk is biased or not?
No, you don't.
And it can be biased. I was in
course.
charge of looking over a talk about 1.5 years ago. It was on a very good drug. It was on Entresto, good drug for heart failure, right? But the way they worded the question, and I knew that the person speaking had received money for the CME talk, was that, and the next drug you should choose is, you see? And they left out for this particular patient on the answer. The answer is Entresto. The answer was Entresto. They would show it to, it was televised, and they'd show it to the audience. But since I was going to moderate this before we began the talk a week before, I said, you know, you never mentioned anything about spironolactone, and you didn't give it as a choice. Why can't that be the next choice of drug?
Right.
Spironolactone costs 20 cents. Okay. Right.
Yes.
The other drug is $6,000 a year. So you see how they can manipulate. Oh yeah, we made an error. Yeah, you're right. We should put that, and then we'll, you know. So again, there's a bias here in everything that is funded by pharmaceutical, even if it's CME. You want to give another talk on CME? Well, the sponsor wasn't happy with the way, you know, you discussed heart failure or angina or whatever it might be. Because again, you need to be 100% honest. 90% honest is not good when you're talking about patient care. It's 100%. Just like I told you, when it comes to patient care, I'm an imperfect person. But when it comes to patient care, when I see a patient, everything for me is forgotten. I have one goal: make you feel better in the most cost-effective manner that is possible. That's it. I'm not thinking about who's going to take me to lunch, who's going to give me a talk. That's why I stay away from that stuff. Never took it, right?
And along this line, you know, go ahead.
Yeah, and how does that make me amongst the community when I don't go out to dinner? Hey, Levine never comes out to dinner.
You're the black sheep.
Go out to dinner. It's not good for me. You see? They twist it around. I've had pharmaceutical reps say, oh, darn, why did I end up with you, Dr. Levine? And I mean, you mean because you ended up with someone that's completely honest? I'm not going to use your drug. I would tell them, there's no way in the world. They'd wait outside, wait there. And I felt bad because I understand I have a job to do. So I'd approach them. I wouldn't let them come. I'd approach them in the hall and I'd say, look, there is no way I'm ever going to prescribe your drug. Okay? Is that clear? I'm very, and someone would say, why me, doctor? And I'm like, oh my God. You mean why you ended up with an honest physician who's not, okay. But it's the way it is.
Of course, of course. Now, along this line of, you know, pharmaceuticals and as well as cost effectiveness, why is it that, you know, in the United States, we often pay more for drugs than, let's say, people in Canada? I've heard of people even taking trips to go up north, especially those in New York State. You know, you just drive a couple of hours past Rochester, you're into Canada, and you get the drugs. Yeah.
So when I wrote my book, one of the excuses for pharma was that we need the United States to help pay for funding. And so in my book, I basically look at all the drugs that were discovered in Japan or in Europe. And so why am I paying 3 times as much? They discovered, I'm not helping funding that. It's a joke, okay? It's a darn joke. Why? Because our politicians are being, I'll use the word bribed. There's something going on there. Let's face it. you know, one of my favorite quotes to my kids is from Mark Twain. It says, "Politicians are like diapers; they need to be changed often." You know, they're full of you know what. So
Yeah.
that's the answer. The answer is we're stupid, and somebody is being paid off. It's crazy, absolute craziness that we're paying 3 times as much.
Hence why you tend to prefer generics. And a lot of people may not, some people may not know that generics are bioequivalents to the brands. You know, they do identically and virtually the exact same thing. And theoretically, they're supposed to work in the exact same way. You know, so some people might be attached to the brand given the fact that the brand's been out longer, or even that the brand has a catchy commercial.
Yes, I've had people who don't know better. Sometimes they're on Medicaid. So if I write a letter for them, they can get it branded. And my answer to them is the following. I take generic, my wife takes generic drugs, and my children take generic drugs. I'm not writing that for you. If you want to go to another physician, go ahead. I refuse. I refuse to write it. I never have.
And oftentimes the process is lengthy just to get the DAW dispenses written. You know, a lot
but
of
I take generic. They don't understand it. They think there's something special.
Yeah.
And what people don't realize is that there's money in generic drugs. So some of the big pharma branded pharmaceuticals actually also make the generic. Maybe on a Tuesday they'll make the generic, and a Thursday they'll stamp it branded. Now, don't get me wrong. There have been some problems with some of the generics, some overseas, etc., with the manufacturing facilities, and the FDA came down on that. But it's also, they've had problems with branded drugs too. They've had problems with branded drugs, the humidity in PR and things of that nature, and the branded drugs, they had problems over the years. So again, I take generic drugs. My children take generic drugs, and generic drugs aren't as inexpensive as they were years ago. They're getting smart. There's probably some collusion going on there that, that behind closed doors that they're saying, don't charge too little on the generic, I'll charge this amount. The generics aren't what they used to be. Now, pharma's really smart, right? But now we all have these tiers, these copay tiers, right? You could have a tier 3 drug, and let's say it's $100 copay, right? And if you're taking it chronically, it's $1,200 a year. It's a lot of money. So now the pharmaceuticals, they get really smart, and they said, if you use this card,
the coupon cards, a discount
card, it's going to cost you only $20. You see what they do? They defeat the purpose of the tiers. The insurance companies want to reduce the insurance companies don't give a crap about you either, but they want to reduce their cost. They want to make it difficult for you to get that drug. So they put it as a tier 3. But then the pharmaceuticals come back. They don't care about you either. They want to make the sale, and they give you the coupon. So now they're basically paying $80 of your copay, right? But since the med's $350, they're still making out okay. It's a game. It's crazy. Look, I am a devout capitalist, okay? But there are certain situations where capitalism doesn't work. And when I bring this out to people, is like, imagine if we had private firefighters, okay? Right? Cedrick did not pay the firefighters this month, and his house is on fire, right?
I'm done for.
Cedrick. Sorry.
I'm done
Your
for.
house is gone. Okay, we can't have that. Same thing with healthcare. Same thing with healthcare. Again, government screws up a lot. Yeah, but we need single payer universal healthcare. Goodbye. That's the end.
Right.
That's the end. Everyone has the right to have healthcare. And the funny thing is, people with Medicare and Medicaid, they probably have better healthcare than you and I now anyway. because they're open. They can get everything. You and I can't. We have a $5,000 deductible. People have this notion that we're giving up something. We're giving up nothing. We're giving up. What we're doing is we're being told a story by these insurance companies that are just taking money like middlemen. Okay?
Yeah.
It's a joke. And the same thing from pharma. Imagine if the government said to pharma, we're only paying this. We control all the prescriptions in the United States. You want $500, France is paying $200. We're going to pay $200.
That's
Take
right.
it or leave it.
They'll take it.
Right?
They'll
take it. Exactly. So we're behind the times here. But we live in America. Look, we're the only country that never made it to the metric system. So it's kind of like the same thing with the healthcare system. We just won't budge. But what I see is a big mess, a costly big mess that gives us overall poor healthcare. Okay? Lack of choice, a huge burden, high deductibles now where people are afraid to see physicians. We have to push universal health care. No one should have to worry about going to the hospital in the middle of the night. No one should have to worry about paying a hospital bill. No one should have to worry about paying for their Eliquis or whatever it might be.
Right.
It's craziness.
And to that point, Dr. Levine, I want to talk about medicine in crisis. I want to talk about how we find ourselves in this position. So going back to something you brought up, you mentioned earlier on, all of the tests that are often prescribed. Okay. It's true. I agree with you that people should play an active role in questioning their doctors. You want to know why they're prescribing or they're writing for this test. You want to know what the benefit will be to this overall diagnosis. But here's just to play a little bit of devil's advocate, let's talk about defensive medicine. The idea that a doctor could say, well, if I miss something, then the patient has grounds to sue me. I have to.
The ultimate excuse. Listen.
Yeah. What can you elaborate on that?
I practiced in the Bronx for over 25 years. Saw thousands of patients. I'm knocking on wood now, by the way, okay? You know how many times I was successfully sued?
Wow.
Do I practice defensive medicine? No. I document everything. I go by the guidelines. The biggest BS there is this defensive medicine's crap is a reason to do things, okay? And it's not good. When I send someone for a test, every single time, I tell them why they're having the test. Every single time. I said, let's say you need an angiogram. You need a cardiac catheterization because blah, blah, blah. It's invasive, but my feeling is that you have a risk of a heart attack. Okay, I explain everything. I've seen patients, poor and rich, same type of mentality, more is better. I saw a very affluent man the other day for a second opinion, and I turned to him and his wife afterwards, and I said, oh my God, what the heck did you guys allow this guy to do this? This person had every test in the book. And he said, and I'm like, didn't you question them? Didn't you question? I said, you had 3 tests that you had radiation, and I calculated, because I have a nuclear background, I said, you know how much radiation you got on those 3 tests? That's equivalent to 600 chest x-rays.
Wow.
Okay? Hello.
Wow.
You didn't need any of it. But he thought thorough. Thorough is a good history. That's thorough. You can get most of your knowledge from a good history. We need tests. No question about it. Yes, we need tests. But so many are just unnecessary. This person had an angiogram. What the heck did he have an angiogram?
Mm-hmm.
I didn't see an indication for that. I saw someone recently that was going to go for an angiogram, and I said, there's no indication for it. It's an invasive test. But again, I'm just saying, small hospital opens up a cath lab. They don't have enough cases. It's very expensive, the cath lab. Okay. Oh, be a good guy. Send us more cases. You see, come on, doctor, send us more cases. We're in trouble here. We need more cases.
Mm-hmm.
Why I like a second opinion, why I like to go to a university hospital. I like academic medicine. I like a hospital that performs lots of studies. And I like a hospital where there's lots of people looking over everyone's work.
Right.
With a huge team of people.
And
accountability
too.
They do angiograms. If you read their advertising on Facebook, even Siemens, open up a cath lab in your office. You know, there are independent cath labs around the country that aren't even in the hospital. Wow. You're going to get an angio. Who would do that?
People will.
That's right.
People
because
will.
It's convenient. But when it comes to your health, convenience is sometimes not the best. Again, staying local, yeah, you know, little things, you know, hernia, colonoscopy, or big things like, you know, you're having the stroke, you got to go as close as possible. You want the best local hospital, obviously, cardiac cath, things of that nature, but you need to stay educated. Mm-hmm. You need to make an educated decision. Mm-hmm. Just like when you're out purchasing your car.
Again, great point. Going back to the car analogy. And that pretty much sums up, you know, a lot of what I felt was needed to be shared with this audience and anyone who's going to go ahead and watch the video at a later date. I think, you know, you highlighted some very important points that even I, someone in healthcare, don't often think about. How much more those who aren't, you know, in healthcare. You know, again, going back to something as simple as carrying your electronic health record with you in your pockets, in your wallet, having your primary care doctor's phone number, and just emphasizing, you know, having a voice, you know, letting it be known that, hey, I want you to call my primary.
Or making sure that when they ask you, do you want to have a My Chart or access to your records, make sure you sign up for that if you're savvy enough to do that. Mm-hmm. Absolutely. You can get information on your phone. Yes.
Yes, sir. Simple things like these will certainly play and go a long way into making sure that you stay alive longer, because these things, when ignored, can be life-threatening. And Dr. Levine documents some such examples of such cases in his book, What Your Doctor Won't or Can't Tell You. Dr. Levine, I want to thank you.
Thank you.
You know, I want to thank you so much for just the book,
Pleasure.
The information, your time, certainly coming on this Sunday and spending this time with us and just, you know, sharing your knowledge with the audience. You know, I'm going to go ahead and stop recording. I have shared your information within the group chat, but I'm going to go ahead and reemphasize it. I do see that we have quite a few questions, and if you'd be willing to stay with us just a few minutes longer, the audience will be able to ask you questions. Now I'm going to stop recording because